Assalamu alaikum. The topic of my today's presentation is recurrent sinusitis with normal imaging. This is Dr. Vizra from Sheikh Zayed Hospital, Lahore. Now, the topic, in my humble opinion, is a kind of an oxymoron. Normal imaging in recurrent sinusitis. Interesting. But before you all start judging me for being a moron, because I have called the topic an oxymoron, I would like to buy myself just 5 minutes to prove my case, my lord. It all started with a 41-year-old female coming to our ENT clinic with a complaint of nasal blockage, discharge, headache that persists throughout the year with incomplete resolution on antibiotics. This patient had an episode 2 days back for which she went to her doctor who prescribed her very high potency antibiotic. She had been to multiple ENT doctors, family medicine doctors, general practitioners, and all of them had collectively diagnosed her to be a case of recurrent chronic rhinosinusitis. Besides the fact that she was taking her medications religiously, her condition worsened. So she walked into our clinic not only to ask for help, but her this much thick folder of previous medical record files and medical prescriptions, all of them were asking to have an escape for the dilemma she was living in, for the ill health that she was carrying all along 41 years. All she wanted was healthy, easy nasal breathing. So, as a good ENT doctor, I started off with her nasal examination, which showed mild right sided DNS, pale, boggy, bilateral hypertrophy turbinates, and on 0 degree there was just clear nasal discharge. For such patients, we have a habit of giving SNOT 22, and her score showed mild sinonasal disease. Probably she was taking that high potency antibiotic at that time. However, to address her chief complaints by then, we gave her topical steroids. To address her chief complaints, we gave her inhaled nasal steroid and good decongestion and antihistamine medications. We asked her to follow up after 1 week with her CTPNS just for the confirmation of her case. But when next week she came in with the CT scans, to our surprise, these images showing clear nasal mucosa, sinuses, patent osteometal complexes, no mucosal inflammation or opacification, a bilateral Lund-Mackay score of 0 and 0. This, ladies and gentlemen, was the climax of our case. We did her follow-up 0 degree endoscopy and we couldn't find any degree of pus, discharge, edema, anything that is indicative of being a recurrent chronic rhinosinusitis case. I know some of you would say she had an acute episode, she took antibiotic, so these images could be normal for her. But my dear, the topic under discussion today, the diagnosis under consideration for this patient today is chronic recurrent sinusitis, and such a scenario with these CT films are not justified. Anyways, picture अभी बाकी है मेरे दोस्त. Let us help restructure the patient's diagnosis under the current guidelines of EPOS and American Academy. Following are the symptoms that make up the diagnostic criteria. And for it to be a case of recurrent rhinosinusitis, two objective tests, nasal endoscopy, and positive signs on CT imaging are essential. My patient had just two major symptoms, nothing from minor or objective tests. Now, considering the risk calculations I have always done in the life decisions I have made, I am pretty terrible at maths. But still, I'll put my humble math services ahead for you and let you know my math is not mathing to get a minimum score of 4 to label it as a case of recurrent rhinosinusitis. Moreover, the duration-based classification of EPOS excludes the patient of the same diagnosis. Now we were in a fix. We prefer to take patient's history again, and this time she told us that patient had episodes of allergies when she is exposed to smoke or perfumes. With the overlapping differentials, we knew one thing for sure. The patient and patient's history and examination, they do not lie. तो तमाम गवाहों सबूतों हिस्ट्री एग्जामिनेशंस को मद्देनजर रखते हुए हमारी ईएनटी टीम इस नतीजे में पहुंचती है, इट माइट बी द राइट टाइम टू reconsider the diagnosis. It might be allergic rhinitis or clog rather than the recurrent rhinosinusitis. So we give her a good anti-allergic treatment therapy for 2 to 6 weeks. We call her on follow-ups, and not only her condition objectively improved, her SNOT-22 declined, and her quality of life, it skyrocketed. In my humble defense, I would say history, examination, imaging, guidelines. All are there to support your diagnosis, not the other way around. So, in case if your imaging is going against your diagnosis, take a moment. Revise your patient's history. Do not rely on patient's diagnosis, previous diagnosis he has been carrying, or the imaging he has been getting you with, because sometimes the imaging can be deceptive. Our strategy for treating this patient was the same as we treat every other patient, to treat the patient overall. So when our patient walked in to just get her sinusitis episode treated, we improved our patient condition on a 360 degrees. Today she is in her best of health, shukr alhamdulillah. My take home message is to listen to the patient actively, keenly. Use appropriate guidelines to make your diagnosis. Lastly, SNOT-22 is being heavily neglected. If properly employed, it can be a source of light and guidance for our young doctors in our ENT clinics. With this message, I would sign out. I hope I have well advocated my case of oxymoron to my judges. Thank you so much. And this is the disclaimer of my presentation. Jazakallah khair.